Not sure whether you are able to join or.
No, sir. I am more familiar with the Zoom platform actually. Cisco is slightly tricky, but otherwise it's okay, sir.
Okay, fine.
So yeah, I will be sharing my screen, sir, later on when you allow me. Thank you so much for inviting me today.
You want to check, then Dr. Deepa will.
Yeah, I will just check once. I think that's
okay, sir. I will give you the privilege for sharing your screen, sir.
Yes, ma'am. Thank you.
I have made you the presenter, sir. You can please check your.
So
Your screen is visible, sir.
yeah, I think that should be fine now. So I'll just stop it right now.
Yes, sir.
Okay, thank you.
Dr. Kotur is our dean.
Good afternoon, sir. Thank you so much
Doctor, sir.
for inviting me.
Hello.
Thank you so much.
Your face is not seen.
Welcome. Thank you so much, sir. Thank you so much for calling me for this session. It's a privilege, sir.
We will start in another 5 minutes or so.
Yes, sir. We'll start in.
Why that disturbance in between?
Sir, my voice is not clear, sir. Is it clear, sir, my voice?
Yeah, your voice is clear.
Your voice is clear, Deepa. Very clear.
Okay, sir.
Very clear. Deepa, I think you can start. It's already Dr. Deepa. Deepa. Dr. Bhatt, are you able to hear me?
Yes, sir. We'll start now. We are able to hear you, sir.
Yeah.
Good afternoon, everyone. Myself, Dr. S. Deepa, Member Secretary Scientific, will be hosting this program today. I welcome all the participants of this webinar, Forefront of Future Frontiers, a popular by the name FFF webinar across the nation. A medical webinar series to translate novel scientific innovations and integrate them into practice. This is hosted by Scientific Society of Aarupadai Veedu Medical College, Vinayaka Mission Research Foundation. At present, we are in Series 10. After successfully completing Series 9, and we had Golden Jubilee webinar also sometime back, the theme of this Series 10 is putting patient first, quality and safety in healthcare. Today in series 10, episode number 54, we have an important topic of discussion in quality and safety in healthcare. That is improving the perinatal and neonatal outcome, the QA way. And we have a resource person from a reputed institute, Lady Hardinge Medical College, New Delhi, Dr. Vikram Datta, Director and Professor, Department of Neonatology. Now I'd like to invite our beloved Dean, Dr. P.F. Kotu, sir, to give the opening remarks. Over to you, sir, please.
Yeah, thank you, Dr. Deepa. On behalf of our university and the management, I take this honor of inviting or welcoming our today's resource person, Dr. Vikram Datta, for this FFF platform, which is this is the 54th episode. As Deepa already said, we had a successful silver jubilee and followed by golden jubilee, and now we're heading towards diamond jubilee. It is a consecutive, Dr. Vikram will be happy to know that the consecutive 54th episode, which started in a humble beginning last year when we were all stuck with unwarranted COVID pandemic, as a small service to the medical fraternity to drive away their claustrophobic environment. We started that, and certainly we are very proud that this platform has got a follow-up of nearing 10,000 participants, and various eminent luminaries have academicians, scholars, teachers, scientists have shared this platform with their expertise, knowledge, and wonderful. I welcome Dr. Vikram Datta. Of course, Dr. Vikram Datta will be introduced later by Dr. Bhatt, his own cult. Dr. Bhatt is also a pediatrician neonatologist. He will be doing that. But prior to that, I cannot stop myself by expressing a couple of thoughts. When I Googled out about Dr. Vikram Datta, I was, so much fascinated, and I felt happy to note that a pediatrician turned into neonatologist, finally resorted to he is a WHO, and he was to in these past couple of decades, it has been wonderfully done. And about our Indian neonatal and infant mortality, many indicates still not yet up to the mark, compared to many developed countries. And in such a such a situation, we have a wonderful person who has dedicated his profession for his life for this, especially for and in a developing country like India. We'll have a very wonderful sharing of his experience for the next almost some 45 minutes to 1 hour. Once again, Dr. Vikram, I welcome you all, and I welcome the participants. Participants from across the country are over here. So with these few words, I thank you very much, Dr. Deepa. Over to you.
Thank you, sir, for your kind words. Now I'd like to invite Dr. Vikram Datta, sir, Director Medical Research, Professor Neonatology, Aarupadai Medical College, to introduce our speaker. Sir will be the appropriate person to introduce our speaker, Dr. Vikram Datta, sir. Over to you, sir. Dr. Bhatt, sir.
Respected Dr. Vikram Datta, our Dean Dr. Kutu, Dr. Deepa, and all senior faculty members. On behalf of Vinayaka Mission Research Foundation and the University, I welcome you, and it is my pleasure to introduce you to the audience. Dr. Vikram Datta is known to me for many years. He worked in not only in the neonatology field, but also in National Neonatology Forum, the apex body of the neonatologists. He is presently the director professor of neonatology at Lady Hardinge Medical College and Kalavati Saran Children's Hospital, New Delhi. He is also the vice president of National Neonatology Forum. He has been the secretary earlier, and he was the editor of Neonatology Journal. Presently, he is editor of several other journals, like guest editor of BMJ Open Quality, member of the QID working group of the Ministry of Health, and co-chairperson in various other committees. So main interest is in quality improvement. He is working for a long time, and all over Southeast Asia, he is giving talks and training people, conducting workshops, and you will see him in almost all neonatology conferences. He has published several original papers, and he has been one of the lead persons in the neonatal care in India. And today he has agreed to talk us on improving the perinatal and neonatal outcome, because they are the major issues countries like India are facing. And our neonatal mortality is quite high, although it is coming down, but not that drastically. So I think he will give us direction to improve the quality of care and also to bring down the morbidity and mortality in the perinatal and neonatal period. So it is my great pleasure to present Dr. Vikram Datta to the audience. Dr. Deepa, back to you.
Thank you, sir, for such a brief introduction. Like Dean sir was telling, his CV was very huge. I was not able to make a simple PowerPoint out of that. We have, regarding this quality, I think this is the first talk we are hearing about the quality. We had a Coursera free for us during this, our institution had made Coursera free. That time we had many courses on quality improvement strategy and safety, patient safety. That was by John Hopkins University and other universities of abroad. I hope in a developing country like India, and how to improve the quality, especially for the neonatal outcome, which is to decrease the perinatal mortality rate, which sir was emphasizing. I hope this will be an eye opener for all of us, all the healthcare professionals who are attending this program. Thank you, sir. Over to you. Over to Dr. Vikram Datta, sir. The screen is yours. You'll be able to share your screen, sir. I'll make the first one.
Yeah. Thank you so much, ma'am. Good afternoon, all of you. My special regards to respected Dr. Kotur sir, Dr. Vishnu Bhatt sir, Dr. Deepa, all esteemed faculty members of AVMC and friends from all across India. It's a pleasure and a privilege to be a part of this distinguished gathering. And as I'm told, this is the series 10th and the 54th webinar sequentially since the pandemic struck. I really compliment AVMC and the Educational Society there, especially the efforts of Dr. Deepa under the guidance of Dean Sir and Vishnu Bhatt Sir for undertaking such an educational activity free of charge for the people of this country. Sir, it is deeply appreciated, and we will make our efforts to spread the message far and wide across our networks so that people join and take benefit from these remarkable sessions in the future times to come. So with this, I will just share my screen. and start with the presentation, and I'll try and keep it interactive. So the session for today is entitled Improving Perinatal and Neonatal Outcomes the QI Way. Well, when I say the perinatal and the neonatal outcomes, many of you here today may not be neonatologists or obstetricians, and you may be wondering what I'm doing sitting in this session where a neonatologist is going to talk about perinatology and a neonatologist is going to talk about quality, whereas he is not qualified to talk about quality. He's just a neonatologist. Well, that is exactly how I used to also think nearly 7-8 years back, when I was thinking that I was just a neonatologist and there was very little I could do to fix the complex problems of the healthcare system, and my domain was entirely in the neonatal ICU. But friends, I take you here with the first slide here, which says that the goal of improvement in a crisis setting is to ensure and improve the best patient outcome in systems which are under acute strain, while at the same time placing a minimal or no additional burden on the stressed healthcare staff. So I start here by paying my heartfelt gratitude to the healthcare staff and the healthcare systems which have been severely stressed in times of pandemic and who are trying their best to give high quality care to patients, give them the safest care and the best clinical outcome. And we've just moved out of the second wave of the pandemic, and I'm sure all of us have a personal story where patient safety was compromised, where we were stressed, where there were burnouts, where quality was compromised, despite the best of our intentions. And I'm sure that today when you walk into this session with me, you will make sure that you learn some practical steps. And this is just a sensitization session. Quality is a continuous learning exercise, my friends, that we have to continually learn it, adapt towards it, and try and ensure that our patients get the most safest care. So I bring greetings from my organization, which is a young organization. It's called Nationwide Quality of Care Network. It's a voluntary organization present across 15 states of India, which is impacting the lives of over 1 million people and nearly 500,000 plus mothers who've delivered till date. We've got a large presence across India, and now we've extended through the digital platform, which have been authorized by the WHO CRO across Southeast Asian region of the Asian subcontinent. So I will start with the first slide, which will make you wonder and think about the main gist of this presentation. Well, if you look at what is written here, and that struck me when I was looking at the data, 75% of newborn deaths can be prevented with high quality care. What does this mean? That 3/4 of our newborns who are dying today in this country or in any part of the world, if we provide good quality care to them, their deaths can be prevented. And in India, we can guarantee them a life expectancy at birth of close to 69 to 70 years. Well, this is easier said than done. When you look at the global perspectives of neonatal death, you'll find that there are 2.6 million neonatal deaths, which is nearly half of the chunk of all under 5 deaths. Nearly 7,000 newborns are dying every day, and 1 million newborns die on the first day, and another million die on the first week. The worrisome fact is that 98% of this mortality occurs in the low and middle income countries. And mind you, just to remind all of you, and I'm sure all of us know that India is a part of a low and middle income country categorization. So this is something which is for us to worry. And when I go at the neonatal mortality, you will realize that the neonatal mortality rate of India is the largest in the world. Close to 26% of all global newborn deaths happen in India. When I talk about neonatal mortality, we very easily forget about something, and this is called the underreporting and the easily forgotten data about the stillbirths? Well, if you look at the global stillbirth rates, the 2 million stillbirths, and most of these babies were born stillborn just before being born. That is 50% of these were intrapartum stillbirths, where death occurred after the onset of labor. And that is when the mother was in labor. She was expecting a lusterful, crying baby full of life and vigor. And what she gets is a dead baby. And think at the tragedy which happens at this point, a life being lost at the time when we were expecting a crying baby who's full of the natural vigor of life. Well, 98% of these stillbirths, again, like the neonatal deaths, happen in low and middle income countries. Now, I have tried to tabulate some data, the neonatal and the perinatal mortality statistics. If you look at the neonatal mortality rate, global is close to 17.47 and the stillbirth rate is 13.87. Well, when you look at the neonatal mortality rate of India, it's obviously higher than the global average of 17.47, it's 23. But when you look at the perinatal mortality rate, it is 22. But surprisingly, our stillbirth rate is grossly underreported. And it is reported at a rate of 4. Whereas one estimate says that in India, the stillbirth rate is 13.93. And if you look at Delhi, that is the state where I am working, the neonatal mortality rate is 10 and the perinatal mortality rate is 13 and the stillbirth rate is 5. But what does that tell us? I want you to look at the strict urban and the rural divide. Just look at the national average. The rural neonatal mortality rate is nearly twice as compared to the urban neonatal mortality rate. And that is something which is worrisome. It speaks about strong inequities in the care which we provide to the people living in the rural areas as compared to people living in the urban areas. Now, another fact. Now, if the countries continue on the similar trend, nearly 60 countries in the world are going to miss the SDG target of reducing neonatal mortality. And the neonatal mortality SDG target is less than 12. And half of these 60 countries are not going to reach this target even by 2050. Now, the worrisome fact is that these countries carry about 80% of the burden of neonatal deaths in 2016. And this data has been leading us to now come to the... I think there's some background noise, ma'am, if you could just mute it.
Yes, sir. I am trying to.
Thank you so much. So if you look at the preventable maternal deaths, then every day in 2017, approximately 810 women died from preventable causes related to pregnancy, and 94% of all maternal deaths occur in low and lower middle income countries, just like what we have mentioned for the neonatal deaths and the stillbirths. So not only the mothers are dying, the newborns are dying, and also we are having very high numbers of stillbirths, and timely access to high quality care, mind you, can save a lot of lives. So let's now look at whether poor quality of care is a problem which exists only in the neonatal sphere, and why my friends from other disciplines who are here today also need to worry. So if you look at this graph, which is taken from the Lancet Commission, you will find that the cardiovascular diseases account for the highest number of deaths which are attributed to poor quality. But the neonatal deaths account for the second highest number of deaths which happen after the cardiovascular diseases. And that is precisely the reason why Professor Vishnu Bhatt requested me to talk about how we can bring down the neonatal deaths using quality improvement approach. And if you look at the maternal diseases which are attributing to deaths, well, the number is small, but the number still exists. So the highest being cardiovascular deaths, but large number of neonatal deaths can be prevented. 75% can be prevented by giving high quality care. So we all know that this is an era of universal health coverage. We have multiple schemes which have been rolled by World Health Organization, multiple schemes which have been rolled in India, and our key scheme, that is Ayushman Bharat scheme, which is trying to take us towards the SDG goals. And I'm sure the students who are here are well aware of the SDG goals. The most important SDG goal for a doctor who practices pediatrics or obstetrics and gynecology, or any other physician or a public health expert, is the SDG 3. And in SDG 3, the SDG 3.1, which talks about reducing the global maternal mortality ratio to less than 70. SDG 3.2, talking about reducing neonatal mortality rate to less than 12 per thousand live births. And SDG 3.8, which talks about achieving universal health coverage. That is, health coverage should be available to all, regardless of caste, creed, gender, geography, socio-economic status, educational status, anything. We are all moving towards the direction of achieving UHC. And mind you, why we are talking so much about UHC? We're talking so much about UHC because if we accelerate the progress of UHC towards the achievement of the SDG targets, we can save nearly 12 million lives. And out of these 12 million lives which can be saved by achieving the SDG goals, nearly 10.2 million are children. And that is a large chunk. So the direct benefits of achieving SDG 3 translate into saving lives of 10.2 million children and 1.6 million babies. And mind you, 57% of the lives are at stake in only 3 countries. And these are the countries Nigeria, Pakistan, and DR Congo. But does that say that in India we are not concerned? Definitely we are concerned, because I just told you that the largest chunk of neonatal mortality which is contributed globally happens in India. And that is why for us, achieving SDG and universal health coverage is very, very important. So I made a case for UHC, SDG, and high quality care. Now I'll show you a photograph here. Most of you must have seen this. This is a photograph from one of my visits to a district hospital. I'm not going to name the state here because I don't want to identify the state here. But this is from one of my visits, and I'm sure Vishnu Bhatt sir would be very familiar to these SNCU setups. These are district hospitals which are now upgraded to provide a level 2 neonatal ICU facilities. Now this was a photograph which was taken in November 2019. Well, you can see in this SNCU that this SNCU looks pretty organized. And if I ask you, what about quality? You could probably say seems like relatively okay quality. Okay, now let's look at the labor room of this hospital. Now this is a labor room of the same hospital. Equipments are put in water. The plug is out of the boiler. The waste is put into a bucket which is soiled with human anatomical waste, as well as glass, as well as plastics, municipal waste, sharps. And this is how the obstetricians wash their hands. And this is how the nurses wash their hands. The water is often not there, though they put the hand washing guide there. There is a mug, and you can see the cleanliness. This is the labor table. We just lifted it. It was totally soiled. This is the toilet for the mothers. And this is a door which was broken. So the respect, the privacy, everything lacks. And this is on a day when I was there with the Niti Aayog team, which was there to inspect this hospital. So you can understand that if you reach unannounced, what would be the situation in this hospital on that day. And friends, this is not the situation only in this hospital. This is probably the situation in most of the parts of the country in public sector settings. Now, just think, if you deliver a baby in this labor room, and this baby, despite the best of your intentions, lands up into an NICU, which you feel is pretty good, you think the baby is not going to carry infections? What about the respect of the mother? What about the postpartum respect for the mother? What about the patient satisfaction score of the mother? What about the risk of infection to the delivering mother? I'm sure all of it will be severely compromised in such settings. Now, when we talk about the national institutional delivery rate, Government of India is trying that most of the women now come to hospitals and deliver. We are incentivizing these schemes. Treatment, transport, everything is free. There are some cash incentives also. In urban areas, close to 90% of mothers reach the hospital. In rural areas, close to 75%. And overall in India, nearly 80%. Now, when 80% of mothers deliver in hospitals, don't you think they deliver good antenatal care? All of them? Don't you think if needed, they would require cesarean section, they would get the cesarean section? Don't you think all their children who are born would receive breastfeeding? And don't you think that they should be exclusively breastfeeding? And the baby should be visited postnatally for any signs of illness or disease. And if there is an emergency, the mother should receive blood bank facilities, good anesthesia facilities, and safe cesarean facilities. And postnatally, these mothers are taken care of. But friends, as you can look from the left side of my screen, the data is from the Global Quality of Care Network of WHO under the country dashboard of India. We have a long way to go. We have seriously a long way to go when we look at the critical MNH processes of care. So that brings me to the next question. We've increased the coverage of institutional deliveries or SNCUs across the country. So the question here to this August panel is coverage synonymous with quality healthcare? You may type in your chat boxes if you feel that if you increase the coverage, it automatically improves the quality. You can write in your chat boxes. I'm afraid I won't be looking at it because that will divert me from my presentation. But I'm sure Dr. Deepa would be just looking at it and later she can tell us the answers to make it more interactive. Now let's show you a data. This is a data which plots the neonatal mortality rate and against the percentage of birth that occur in the health facilities. So if you move towards the right, the proportion of institutional delivery rate is high. But if you look at the vertical axis, the neonatal mortality rate is increasing. Now let me draw a line. So I've drawn a line where I'm trying to see that facilities with similar coverage, what is the neonatal mortality rate spectrum? So the closest which I can see here is, I can see 2 states. And if you see here, these are the states with the high coverage, same coverage of institutional delivery rates.
20
So can we mute everybody, Dr. Deepa, please? But these states have got, the state of Uttar Pradesh has the same coverage as, nearly the same coverage as the state of Manipur. But you can see there is heaven and hell difference between the state of neonatal mortality when you compare the neonatal mortality across both the states. Now this slide is courtesy Dr. Margaret Crook from the Lancet Commission on Quality. And you can see how coverage does not translate into quality across states. So what does it mean? Universally increasing the coverage cannot guarantee high quality care. So now let's look at the mantra. So how do you give high quality healthcare? So utilization rate, institutional delivery 80 to 90%. How do I get 80 to 90% health coverage? What is the missing link? There is a missing link, friends, and that missing link is quality. So your utilization 90% of health services, quality 0%. You take a product of both of them, 90 into 0, health outcome 0. So we need to understand that the missing link in the health systems of all LMIC settings right now in the developing world is quality. And unless and until we pour quality into our health systems, the health outcomes, like I showed you in the previous slide, the Meghalaya and the Manipur and the Uttar Pradesh example, you can't guarantee proper health outcomes. And ultimately, it is the health outcomes which are important. So I'm sure by now you must be thinking, how do we reduce these variations which you just saw on the previous slide? And how do we decrease our health, related mortality related outcomes to achieve international SDG targets? Because, ultimately SDG targets take us to the era of universal health coverage. And that is something which we want to achieve. Well, there are some answers. If I had time, I would have done a poll, and I'm sure these would have been the answers. Some of you would say, let's build more hospitals. Let's upgrade the hospitals. Get us more ICUs. Let's get more manpower and equipment. Let's develop some good guidelines to guide people. Like in COVID era, every day you see we are getting new guidelines. Okay, every day we are getting new guidelines. Let's train people into the recent evidence-based guidelines. Let's give them some incentive if they work well. Let's motivate our staff, either personally or in group. And let's make the community partners in healthcare. And lastly, let's aspire for a quality assurance program. Let's get a NABH certification or a JCI certification and say that we are the best. We provide high quality care. Well, these could be some of the answers. But let me just tell you here that these are only temporary solutions. And when I say temporary solutions, you may question me. You may ask that these work. These have been working for years, and this is what we do in administration and as teams. And you are saying that these are only temporary solutions. And why do you say that? Well, I have evidence to back my statement. And the evidence is, I will just show you the evidence from Lancet, a recent systematic review evidence, which talks about how health worker behavior can be changed. What strategies change the health worker behavior most? And that is a very interesting slide. And I'm sure it will change your perspective towards your future sessions. So before I go to that interesting slide, I would just like to show you here that what is the effect of universal health coverage on saving lives. An estimate from WHO report released in 2020 says that if we focus only on care around the birth practices, there is an effect size of 46% reduction in maternal mortality rate and 40% reduction in stillbirth and neonatal death reduction. And mind you, my friends, that this estimates that the impact of this is saving 3 million lives. And 3 million lives is a big number. Approximately, it is equivalent to the number of people who've lost their lives in COVID pandemic till date. Of course, it's plus 3 million right now. So if we just focus on care around the birth, I'm not saying that we could get back those lives, but at least we can prevent an additional 3 million lives from being lost if we can provide high quality UHC care. Now, this is something which is very, very important. There are a lot of challenges. If it was this easy, 40 to 45% reduction just by focusing on care around the birth, why we can't do it? Well, Lancet has estimated that globally, 5 million people are arriving in hospitals thinking that they would get good quality care and would go back home walking. Instead, they go back wrapped up in shrouds on the shoulders of their brethren to cremation grounds. And this is directly attributed to poor quality of care. Another 3.6 million people cannot utilize the health system. And that is the reason, because of poor access, social determinants of health, etc. But we cannot do anything. But as doctors and healthcare providers, we can concentrate on these 5 million people who reach the hospital and lose their lives to poor quality of care. Let's take a vote today that when some patient comes to our hospital, we'll give the best quality care and try and address this issue. So the Lancet Commission on Quality says that 75 to 61% of newborn deaths are due to delivery of poor quality care as opposed to non-utilization of care. So why it is so difficult to deliver high quality care? You may just say that we know the evidence-based best practices. We've read books. We've had, sessions like these where experts come and tell us what to do. But why does it not translate into on-ground action? Well, these are 3 photographs, a small quiz for all of you. Can you guess what is the level of the facility from which these photographs are taken? You can again write your answers in the chat box. What is the level? Is it a medical college? Is it a district hospital? Is it a primary health center? Is it a sub-center or a community health center? And where exactly are these photographs taken from? Which part of the country? Just look at these photographs for a second. Dr. Deepa, you are the most easiest person to whom I can communicate. Dr. Deepa, any guesses?
Yes, sir.
Any guesses? The left photograph from which level of facility?
That can be even in a medical college in India sometimes happens.
Yeah, so I'm sure Dr. Deepa is absolutely right. So you get 100 marks out of that.
Sir, I am an obstetrician.
Yeah, ma'am. So you can see this is a photograph of a postnatal ward from a medical college. And again, this is a labor room in a medical college in Delhi, and this is from the state of Bihar. And both of them are on a Government of India scheduled pre-intimated visit day. So you can understand what would be the situation when there are no visitations or no monitoring visits. So what I'm just trying to tell you, we all know 6 steps of hand washing. How many of us wash our hands? We all know 5 moments of hand hygiene before COVID. How many of us were washing our hands? We all know labor room best practices, ma'am, you're an obstetrician, but we still continue to do actions which are not recommended. And this all happens. And that brings me to the next question. Do guidelines translate to better care? And I'm sure everybody sitting here now would agree with me that globally, guidelines, just making the guidelines, sending them across, doing sessions like this, not going to bring about a change. Because in low and middle income countries, there is less than 50% compliance to evidence-based actions. Even in developing countries and developed countries, right across the globe, there's some factors which happen in between. So there is a gap, and I'm going to address this in a slide. And this is a slide I was referring to previously. It's a beautiful slide. I really love this slide. It's based on Rowe et al.'s article in Lancet. This is a systematic review of interventions to improve health worker performance. And it just tells you that if you train, and in India, we are very, very, fond of training. 90% guys are not going to change because the effect size is only 10%. If we give them an app, these days we are very, very fond of making apps, digital books, predictive, algorithmic based, AI based, technology solutions. 99% of people are not going to change. We give them books, we courier them books, we print the books. Earlier, pre-pandemic, it was very much in vogue. A lot of professional organizations were sending their guidelines. 98.5% people or 98.6% no effect. Incentives, 98, 99% no effect. Training plus supervision, 82% no effect. So what has the effect? the greatest effect it has been seen is in changing the health worker performances if you club your clinical skill building training with quality improvement. And that is precisely the reason why I'm here today, to tell you that if you learn about quality improvement in greater detail and make it an essential component of all your clinical trainings and your implementation exercises, you can achieve the highest effect size. Still, you will see that 44% of people are not going to change. And that is the highest effect size you can have. But if you miss out on the quality, the effect size is dismal. And I'm sure Dr. Couture sir, Dr. Vishnu Bhatt sir, you will all note this. And we will inbuild quality into our ongoing programs for the benefit of the community at large. So let's quickly come to attributes of quality of care. My job today here is not to talk about quality, details of quality of care. My job is just to sensitize you. So attributes of quality of care is that it provides safety. It is providing effectiveness based on compliance to evidence-based guidelines. It is available to people in times of need. You give the best possible care to a MI patient 3 hours after he's had a MI. He's going to have a very poor outcome. Efficient, delivering healthcare in a manner that maximizes the resources, very important in pandemic times. Equitable, like I just showed you the rural-urban divide. The mortality rates of the rural population being twice in the 21st century in India or any other LMIC country speak of serious issues in equity. People-centered, being driven by the patients, for the needs of the patients or the community, by the community. So if your health system, just do a checklist, quick checklist, at AVMC or any other center, are you giving all of these components into your health system? And the most important part, I would say, is people-centered, and that is where most of us lack. Are we making our patients partners in the healthcare? That is something which is very, very important. So that brings me to the steps of quality improvement. Don't worry, I'm not going to be going into the details. But to know more about the steps of quality improvement, visit our communities of practice webpage, which is available at NQOCNCOP.org. These are the 4 simple steps which are propagated and which are ratified globally. For this is one of the simplest way in which you can learn quality improvement. And we've got a free self-paced course also developed in sync with Infosys Technologies, which is available at this website. You can enroll for it. It's a 6-hour self-paced course, and you can get a certification in quality improvement right from the website. So go ahead and enroll for it. Learn more about quality improvement. So I'm not going to be talking about the steps of quality improvement, but I'm going to share some quick QI stories. Now, this is one of the initial works which my team did in Kalavati Saran Children's Hospital, and I'm sure Vishnu Bhatt sir would be aware of it. This led to, this was a simple project. When we started in Kalavati Saran in the month of June 2016, we realized that 83% of our newborns are arriving hypothermic in my neonatal ICU. And that was leading to significant morbidity and mortality. We did a simple quality improvement project, which led to a 90% reduction in moderate hypothermia. And commensurate with this, we achieved a 38% reduction in death per 1,000 patient days and a 71% reduction in late onset sepsis per 1,000 patient days. And when we calculated this using the LIST tool, we found that 84 additional babies were saved in one hospital with one intervention. This got widely published in BMJ and WHO and also the Hindu newspaper. And I just talk to you here and request you to think about the replicative potential of this work. If 84 babies can be saved with a simple intervention to keep them warm with quality improvement in one hospital with one intervention, leading to 38% reduction in mortality, just think if you replicate it to a larger set of hospitals across Delhi or to across states or across the country as a collaborative, what would be the potential? We also did some work on reducing the light and sound in NICUs. You can see the intervention limbs in orange, and there's a significant reduction. This is a part of the developmentally supportive care unit. These are photographs from my unit in New Delhi. We did some work in Meghalaya where the government requested us to club the quality assurance and the quality improvement model. So to achieve quality assurance, that is a certification, you need quality improvement. Quality improvement is a continuous process. It's like attending the school every day to be prepared for the board examinations. You can't just one day go and give the board examinations. You have to attend the school every day. And this is the quality improvement, quality assurance model, which led to improvement in kangaroo mother care, early initiation of breastfeeding and skin-to-skin contact. HIE, hypoxic ischemic encephalopathy, was significantly reduced in inborn babies in Nilofer Hospital, Telangana by Dr. Hema Bindu Singh and her team. Professor Ashok Kumar from Banaras Hindu University, Varanasi, reduced neonatal deaths significantly by a simple intervention in Banaras Hindu University, which used quality improvement by initiating huddles and utilizing a checklist-based approach. Babies delivered on mother's abdomen in Nigrim, Shillong increased significantly. Percentage of deliveries attended by birth companion in labor room of Institute of Medical Sciences, Banaras Hindu University. Mean stillbirth rate reduction, 41.5% reduction in a peripheral district hospital of Madhya Pradesh. Significant increase in the proportion of babies who receive kangaroo mother care in district hospital Jabalpur, leading to a reduction of nearly 2 days in the NICU stay and significant cost reduction, and significant reduction in the mortality rates in Medical College Jabalpur in Madhya Pradesh, just with a simple intervention of washing hands appropriately, using appropriate amount of sterilium per baby, which is quantified in ml per baby. So these are simple interventions. There are lots of interventions in neonatal perinatal health stream, but I would like to take the privilege, being the guest editor for BMJ, and we have a special issue which is coming up just next month. There are certain key articles, nearly 15, 16 articles, which got accepted for the BMJ, and I take privilege here in sharing the key.
You got disconnected, I think.
Yes, sir. Sir's voice is not here.
Sorry, you got disconnected.
Yes. Sir, but his name is seen, sir. he's available.
Yeah.
Yeah, I called him.
You have his
picking up.
number. You have his number. You can call him.
Sir is calling, sir. Sir is calling.
His connection got disconnected. Deepa, you can. Hello?
Yes, sir. I'm able to hear you.
He
He's
says,
not able to join back, sir. He's not able to join.
yeah, now he's trying to join back. You have to give any permission to him to join or?
No, sir. He can join, sir. In Cisco Bix, he can join him.
He'll come back now.
Okay, sir. We'll wait.
Some technical problem on his side. He'll come back. We'll wait for 1 or 2 minutes. Otherwise,
sir.
he does not able to join, then we can. See. Yeah, he will join with the phone. He will now continue. In the meantime, anybody has questions, they can put in the chat box. So that. I think he has raised some of important issues like making training and making it more effective. So we are not far behind anybody in giving training. So we give a lot of training, but the effectiveness we are not checking because the basic things probably we are not taking care. As he has shown in the pictures, we say that, yes, sir, you can start.
I can start,
Yeah.
sir. I
Yeah.
right. So I
Yeah.
Yeah.
You continue.
Yeah, so I will quickly continue on. I will just try to. I'm so sorry for that hospital internet thing. What I was just saying is how QI can improve neonatal healthcare. I'll try and wind off in another 3-4 minutes time. So basically, QI will help you in identifying the key contextual factors which are responsible for neonatal morbidity, mortality, and any other problem which you have in your setup. Now, once you have identified your problem, the second step is you will form a team, and this team will conduct a root cause analysis of this problem. And with root cause analysis, I say you use a 5 why, or you do a process flow, or you make a fishbone. And I'm sure the course which I just mentioned, which is available on the website NQOCN.org, the self-paced course, which is ratified by WHO, will give you greater understanding of these whole processes. Now, once you've done the root cause, the next step is you will find out that there are multiple problems which are contributing to your problem. Now, these causes, your team will come up with multiple change ideas. You ask your team to give change ideas that, okay, how we can fix. For example, like babies were arriving cold in my NICU. They were arriving cold because they were coming inside the transport incubator, but they were still cold. We tried to find out why they are arriving cold in the transport incubator. And then finally, when the team went to why, we found out that the incubator was not getting charged. And why it was not getting charged? Simply because there was no power lead and no power source nearby. Why no power lead? Because everybody putting the power lead, somebody used to steal it every time. So simple solution from team came, let's put a brown tape over the thing and let the incubator move with the lead. And let's identify places and plug points and say this is transport incubator charging bay. So everybody brings the incubator, puts it at that point, and the plug goes into the charging bay because the plug is moving with the incubator. And as a result, the busy NICU and the labor room setting, the incubator is always charged. It is like you are charging your phone not once when you are coming out from the hospital, but also in your car because you have the charger, also in your office because you have the charger, and also in your seminar room because you have a charger which is attached to your phone. So the phone will never die. Okay. So this is something, the change idea. Now, once these change ideas are taken from the team, they are tested. How do we test them? Is through the PDSA methodology, which is called the Plan, Do, Study, Act cycle. Now, the course is going to tell you in greater detail how you do the Plan, Do, Study, Act cycle, why you need to test the change idea, because the ideas may be phenomenal. They may be given by somebody who's very senior and he says, do like this. But what will be the ownership of these ideas? The other people will say, oh, this is Vishnu Bhatt sir's idea. And when sir has gone on a vacation or sir is not around, they will say, oh, this was sir's idea. But if this idea is coming from Vikram, then even when sir is not there and I have tested my idea and I find that it works, I will make sure I continue to do it. So that ownership of idea will be there. And very important, the second point is that any idea, if suppose by experience, the senior people feel this does not work and they on face of the person say this will not work, then what will happen? The person will not take part actively in the next team meetings or give better ideas which may be coming from them. Let them test that idea on a small scale. If that idea fails, they will themselves not feel bad. And you ask them the other day, okay, you tested your idea. What is your interpretation? They will say, sir, I thought this would work, but this did not work. The mothers it would increase the breastfeeding rate in the postnatal ward, but this did not work. So you will say, okay, then let's try the idea from your friend. And then they will say, okay. So this is called the PDSA methodology. Once you got multiple PDSAs which are working, you will then scale them up. And this is called the scaling up and the implementation of the PDSA. You will create a repository of your knowledge and you will then try and implement into the system and you will then sustain it. The toughest part is sustaining, mind you. Doing a QI intervention is very easy, but sustaining is something which is very, very difficult. So you will learn all this in the point of care quality improvement methodology, which I'm just going to tell you through the course, because now I'm not sharing my screen. So please go to that course and do the course. So the most important point is, at the national level or at your state level or at your medical college level, the first step which you can do to start a quality improvement movement is to get familiarized with the basic tools of quality improvement. And that is the easiest to learn is the point of care quality improvement methodology. The second is, when you have multiple teams across various departments doing quality improvement initiatives, get them on a forum, Vishnu Bhatt sir, get them on a maybe quarterly forum, quality forum, experience sharing forum. Let them all come up and present their small, learning examples. May not necessarily be success stories. They could well be stories of failures, stories of challenges, but at least other people will know how not to do a particular thing, and that is when this will inbuild a lot of confidence in the teams. They will learn from each other. They will learn to communicate, work together as a team, and the hierarchies will break. And that is when you will use forums, online forums like the wonderful forum which you have, to spread this message across the country, get like-minded teams, form a national collaborative. And national collaborative, like we are in the process of doing a national collaborative across Southeast Asia. Also, we are doing international collaborative on care around the birth. You will move towards achieving the SDG and the MDG goals and the UHC goals, which I showed you can save 10 to 11 billion lives. And care around the birth per se, if you focus on one small aspect of perinatal care, it can reduce the neonatal and the maternal mortality by 40 to 45%. So this is basically the key. But how do you achieve this is by, this was a beautiful slide. I wish, sir, I will be sharing the slides. You can then post it in your medical college group. Of course, the results and all are, I will just delete the results because they are from independent teams. Otherwise, the theory part I'm going to be sharing with you. So that can be sent to the teams. So you can reduce the no-do gap. As we become more senior, our knowledge increases, but does our action match to something which our knowledge is? Our knowledge is probably at this level, but the actions are at this level. And this is called the no-do gap. So our aim should be to reduce the no-do gap. What we know should translate into on-ground action. And that is the no-do gap. So the basic mantra for achieving quality improvement is to bridge the no-do gap at the point of care. And that is something which is very, very important. So why India needs quality improvement? Last but one slide. We have a wide spectrum of complex problems. So once these complex problems are there, we also have resource constraints. There is lack of ownership and empowerment. The system is strongly hierarchical. And there is a lot of focus on external mentoring support. Project mode. Somebody gives us money, USAID, WHO, UNICEF, they come and tell us, do this, we will do this. Once they move out, the whole system collapses. And lastly, there is deficient community participation. So these are the factors why India needs quality improvement at this point of time, because we need to tackle the complex health system problems which are existing in our country. The Government of India, Ministry of Health, has moved step ahead into this by launching the Suman and the Lakshya program. And we on our part have launched a small community of practice, which is the nationwide quality of care, point of care quality improvement communities of practice. And I've shared the address of the communities of practice earlier with you. It was inaugurated by Professor V.K. Paul in August 2020, the same time probably when you and your group started doing the webinar series. It is now extended to the Southeast Asia platform, and anybody can visit it. I would encourage members to go to the website, visit, and learn quality improvement using the tools of the point of care quality improvement communities of practice. So last, why the clinical trainees should learn about quality improvement? Because it gives them a chance to improve care at bedside, develop their leadership skills, improve their presentation and time management skills, and help in their career development and building relationship with colleagues. For senior consultants, especially at the level of Professor Bhatt, Dr. Deepa, Dean sir, it will give you an opportunity to address your long-standing concerns about the way in which the health system processes and systems have been delivering suboptimal care. You always thought we could do better, but somehow things happen and we get suboptimal results. How to improve? Every day speaking, telling people, trying to motivate them, somehow things happen the same way. This is the tool which can change health worker behavior. Let's use it to strengthen your leadership for improvement skills and apply important capabilities to manage complex factors in the health system. And very, very important, sir, when you learn about quality improvement, you learn how to manage the human factors which operate in the health systems. And mind you, these are the human factors and the psychology of change, which is again one of the very important frameworks which operates in health systems and is very, very important. And it's a major bottleneck. If we don't address the complex human factors, the health systems will not deliver optimal care. So with this, I am going to be ending here. I'm sorry for the technological glitch. If there are any questions, I would be very happy to answer. Thank you so much.
Thank you, Dr. Vikram Datta. This was indeed a very important session for all the healthcare professionals. Viewing attending your this one very important and a new topic to us, which I was telling you already. I was wondering whether there is anything in India which is available for us to improve the quality of care. I was telling we have been doing Coursera courses of John Hopkins University, where they were addressing about American style of healthcare, which was little bit higher level. But we saw the labor room there in India. So how to improve that? You have given. I have put it in the chat box for all the participants, so that you can go to that website and we can get the training, get it done there, so that we can serve our own society, developing country like India. And thank you for the wonderful session. And you have gone through a very important thing which I saw was how to change the healthcare worker behavior. I was wondering what sir will be telling. It is very difficult. He has pinpointed that the financial incentive has got the least. It has only 1.8%, because the involvement and the quality cannot come by finance or anything. It can come only by clinical training, and per se the person should have the involvement to improve the quality. So repeated clinical training and imparting the quality improvement among the healthcare workers only can give the optimal results. And it was shocking to see that high quality healthcare can decrease the maternal mortality rate by 46%. That is really quite high. We have been trying all our efforts to decrease the maternal mortality rate by increasing the equipments, increasing the manpower, and so many things are there. But it is said that small things can make a big difference. Small quality improvement can make big difference of decreasing the maternal mortality or the neonatal mortality. That is true. And sir was impinging on steps in quality improvement. I myself have a question. He told the steps in that fourth step he told is the sustaining. I was thinking about this, how to have a sustained improvement. First time we give the training, we tell everyone go and do this. But after 6 months, this happened with NABH in our college also. First we give the training, everyone should follow this, everyone should follow this. Biomedical waste management, hand washing techniques, WHO surgical checklist, this one, that one. And that happened for 3 to 4 months. But how to have that sustained quality of care? How to have that one? That's my very certain.
I think, ma'am, that's a wonderful question. In fact, that's the most tricky one. I invite you and your team to attend a full, 2-day session, and we're also having 1-day sessions, which is purely online. It's called the e-POKI session. And with the permission of Dean Sir and Dr. Vishnu Bhatt, we will invite you and your team to the complimentary sessions which are funded by WHO CRO, ma'am. And this will be held somewhere 2 to 3 months down the lane. I will make sure that we give the invitations for the full 2-day e-point of care quality improvement sessions with certificate courses for your entire medical college students, faculty. We will be very happy to host your entire team. Well, the point which you asked is something which is very tricky. Now, my hypothermia project, which I just showed you, which started in 2016, thankfully is still sustaining at more than 90%, 85 to 90% normothermia. And on Sunday, we had a meeting with the National Neonatology Forum of India. We are training, the entire 9,000 NNF members across all zones. And we were reviewing the same data of this hypothermia project from the registers, and we were very pleasantly surprised that it is sustained. Sustaining depends on making QI a culture, making QI a way of life, and making QI something which is not seen as an extra work like a NABH accreditation. It becomes your routine work. It becomes gratifying. You see the results, and it is through common shared purpose, and it is through ownership. Like I just told you, when everybody realizes that what they had said is working and translating into measurable gains for the patient, for their own self, for the healthcare system, for the country, that is when, ma'am, the sustenance happens. If we just tell them NABH is coming, this has to be done. The moment NABH finishes, ma'am, it is going to fall back. And next time we have to work doubly hard to prepare for that accreditation. The QI makes sure that next time the NABH can happen even at 2 o'clock in the night. Suddenly, nobody will have to work even, 1 bit extra. It becomes a way of life. It becomes a culture of life. And that is what is the beauty. So please attend that workshop. All of you, we will be discussing all of these issues in greater detail. Invite all your students to that. And it will be WHO certified. We will be very happy to be having all of this.
Thank you, sir. May I request Dr. Vishnu sir to tell your views on this quality improvement in neonatal care.
I think in his usual style, he has presented very well. And of course, whenever you think of any project, anything reduction, will ask a lot of money, but simple things are very important. And as Dr. Deepa was asking, that sustainability, it is all internalization. So initially, people may be hesitant. They do not know this. The simple thing could change the whole issue. Just like he was talking about the temperature control or hand washing, cleanliness. This should get internalized. Let's see, whenever you see a problem, then and there you take action. Whenever somebody asks question why, we get irritated. But I think that is the right thing. Everybody should keep asking question why. So whether it's a research, whether it's quality improvement, always we should think why this has happened. Then only you'll get an answer. I think he has done a wonderful job, and I think definitely Dean will have some comments.
Yes, sir. I request our Dean sir to share his views on this quality.
Yeah, thank you, Dr. Vikram. I have some comment or a question you can say. Now, no doubt, this evidence-based medicine facilitates the quality, to implementing the quality, because you track down the best that is available that way. But we find that there is always a considerable gap between what we find or what we have tracked down for research and what we do in clinical practice. And even in EBM also, the final stage is the self-assessment or the self-feedback and how correctly you did and all. So blowing the whistle on self, that is the one which is very important thing in quality improvement. I just want to give one example that happened here in our hospital. Deepa is also a party for that. I got an information and with a document that the COVID waste management bags were left in such a place in front of the central laboratory. And she is the acting medical superintendent. Then yesterday in our meeting, she said, who is the one, you find out, and you have to fix that person. And of course, she's on the job. That is a different issue. Now, here the issue is the third component of the EBM, attitude or the behavior of the people. You might be having good evidence, everything, but the attitude of the people have to change. Then only the quality improvement can happen. This is one comment I made, and you can respond to that. Second one is, you said no-do camp. No-do camp, as age advances, knowledge increases, performance goes down. But that is not the only reason for not having a quality. There are various contextual issues also. I hope you will agree for that. I just wanted your response for these two thoughts, what I come to my mind.
Sir, I think both of your observations are very apt, and that comes from the knowledge and the experience which you have. So coming to the first point, sir, you very rightly pointed out, it is always said, the father of quality improvement said that a person who does quality improvement has got a heart which is compassionate and truthful. So that is something which is very, very important. And you will just go back to what I was just mentioning, the psychology of change framework, sir. So psychology of change is something which is very, very important. And these days, sir, it has been increasingly being recognized that unless and until we address the human factors which are there, we are not going to achieve quality improvement. Because to achieve quality improvement, first and the most important point is admission. You said self-whistleblower. And that is something which is a wonderful word, sir. You have to first recognize that your system is having some problem. For me, when I discovered that 83% of newborns in Lady Harding were having hypothermia, and I was just going to report it at my forum, my immediate senior told me that you will land all of us in trouble. It will be all over the press. And that is when we told him that, sir, we are going to fix it. And we are going to show to the world. It came up in the press, but it came up as a positive story in the Hindu newspaper, sir. That this is how Lady Harding Medical College has fixed it. So that is addressing the human factors, the psychology of change. And there is a beautiful document of Institute of Healthcare Improvements called the Psychology of Change Framework. It's a white paper, and I refer my audience to that paper. They can just Google it. It's a white paper on psychology of change. Please go through it. How do you deploy the agency? How do you co-produce? How do you co-design? These are wonderful concepts, sir, which I'm sure we are all using in our day-to-day practice, but which need to be, more objectively quantified. Coming to the no-do gap, sir, definitely you are very right that anybody who works in public health, and especially a person of your administrative stature, you very well know that's not only one factor which is responsible for poor quality of care. As it is rightly said, and I had read somewhere, that social determinants of health and various contextual factors account for 80% of the outcomes of the healthcare outcomes. So healthcare outcomes, 20% depends on clinicians' expertise and clinicians' knowledge and his skills. 80% are dependent on the social determinants of health. And recently there has been a paper in the Lancet. I was just reading, I think last week. There is a paper which is a systematic review which looks at the effect of maternal and father's education on neonatal mortality. It's a beautiful paper. How maternal education leads to enhanced survival of newborns far in excess, even in impoverished settings. So, sir, definitely point is well taken. No-do gap is very, very important, but we have to look at social determinants of health. But like we always say, and this is a management mantra here, that there are two things, sir. One is the circle of influence and another one is the circle of concern. We all have two circles. Circle of influence is one which I can change. Sir, if I'm sitting in Lady Harding neonatal ICU, I can very easily change my neonatal ICU first. I'm really worried about global warming, but can I do something very actively? Yes, I can do something very actively, but it has to start from my circle of influence. And when my circle of influence gradually grows, I can bring about the things which are in my circle of concern. On the other hand, if I'm more concerned about the circle of concern, which is much wider, I only every day crib about things which are not happening, then what will happen? The circle of concern, which is the outer circle, will grow, and the inner circle of influence which I am having will diminish in size. and that is a management mantra. It's a QI mantra, which we always believe that all the good work has to start with things which we can fix at home. And that is what, sir, we are trying to do in quality improvement. Thank you so much once again for giving me an opportunity today to be a part of this beautiful session. I'm very sorry for the technological glitch which made me miss out on some of the slides, but I'm definitely going to be sharing it, and also invite you to the next EPOCI session, which we will be doing with WHO over the next 3 months. Thank you so much.
Dr. Vikram, you have another minute.
Sir?
You have another minute, you know. I have one more. Yeah, see, I must compliment, you know, you shared all your first-hand experience, so things prevalent in India, a lot of the quality issues which you said they have been generated over here in India. That's fine. I draw your attention to one slide wherein you said Lancet Commission, one slide, you know, that was at the end. See, the issue is that evidence that is arising out of that paper is based on the systematic reviews of the various works conducted elsewhere. Okay, so how can we apply that evidence of the systemic review of so many works they are done elsewhere, because the conditions will be entirely different. That is, of course, another big challenge. You know, the evidence generated elsewhere to be applied here in developing the underdeveloped countries. That is one issue. That's why even WHO says what we need is not a best evidence, but an appropriate evidence. Right things at the right time, at the right place. Just I wanted your comments on that.
Your point, definitely the point about generalizability, and being a trained epidemiologist myself, sir, I would like to respond to that. The point is well taken, sir. There are two things, sir. One is the Lancet Commission on Quality. The Lancet Commission on Quality is exclusively focusing on LMIC health systems, which are very close to the Indian system. And most of the data in Lancet Commission on Quality, which was released in September 2018, is from the Indian data, Indian subcontinent data. So that is exactly replicable to our setting. Now, considering the Roy et al. Article, which talks about the healthcare worker performance and the impact on various techniques. Sir, you are very right that there would be a lot of contextual factors, but part of the data which has been taken in that, if you look at the studies, are based on studies on the LMIC, as well as the part of the studies are done in the developed nations. But sir, very important thing is that we need to understand the human psychology under situations of stress, like has been very clearly seen in times of COVID, is the same. The feeling of hoarding things never existed in UK, never existed in USA, but there were no toilet papers, there were no green vegetables, there were no fruits. Everything was gone, sir, when that fear struck. So, sir, when that situation is under stress, the human beings behave in a similar manner, and their response to a challenging situation is relatively same. So we presume that what is Roy's et al. Observations are very well compounded by the observations of the Lancet Commission, and they will be applicable to our setting. But you are very right, sir. We need to develop our own contextual understanding. And that is the reason, sir, we are bringing out a BMJ South Asia edition. And I showed you the list of papers from very prestigious Indian institutions. And I invited our teams from South India, especially Puducherry, etc., such eminent institutions, to contribute to getting the data. Pehle, sir, what was happening? Nobody was publishing because of steep charges and also lack of awareness. We negotiated with BMJ. We wanted them to showcase the work from this part of the subcontinent. So our studies are getting included in the systematic reviews which Lancet, etc., will publish in times to come. And it is more representative of our work.
That's great. Excellent. Thank you.
Thank you, sir.
Thank you, sir, Dr. Vikram, sir, for such a wonderful session, importing the importance of quality of healthcare among us, the healthcare professionals. Either it may be a team leader or the team worker. This imparting the quality is very important, which can save lives. I thank all the participants for attending this session. I thank Dr. Vishnu Bhatt sir, Director Medical Research. I thank our beloved Dean, Dr. P.F. Kotu sir, and Head of the Departments, faculties, postgraduates who have enlightened your knowledge on quality of healthcare, how to improve the perinatal and the neonatal outcome by Sir Dr. Vikram's QI policy which he has done. And we have got some response in the chat box, sir, about the session. It was very informative and other things. And I have put the website in the chat box. I request all the participants to go to that website and try to register yourself on the course which sir has told. Sir will be sending an invitation of the course forthcoming also. Hope so.
Definitely.
Thank you. I thank everyone. I thank once again Dr. Vikram sir, and thank you, dear friends. We'll be meeting again in the next week, next Friday, with another session on episode number 55, another session on quality and safety in healthcare. The topic is point of care ultrasound in anesthesiology by Dr. T. Sivashanmugam, Professor of Anesthesiology, MGMCRI, Puducherry. See you next week, Friday. I thank all the participants for attending this session. Thank you once again. This is Dr. Deepa, Member Secretary Scientific, signing off. Thank you, sir. Thank you, sir.
Thank you.